As Betty said, I'm a gastroenterologist and hepatologist, and I've got great passion for the liver because liver is a very forgiving organ. So we'll spend a bit of time for me to share to you about what chronic hepatitis B infection is. And recently there was a CPG guideline that was published in Malaysia. And so I would go through that a little bit as well. So before I start sharing, I want everyone, I hope everyone will remember that in a month's time, on the 28th of July, we are celebrating World Hepatitis Day. So many of us are living with hepatitis B and C, and that can lead to many complications, liver cirrhosis, liver cancer, liver failure. And hepatitis B is actually a very preventable virus. Hepatitis C is very easy to treat now. And so there really is no excuse why we are still living with viral hepatitis B and C. And so we should try to eliminate it as soon as we can. So I'll try to make it a little bit interactive, and Betty has given me the green light to spend a bit of time. So if you have your phone handy, if you can scan the QR code and join this active poll. The first question of the day would be, why is 28th of July chosen as World Hepatitis Day? Is it because it's an auspicious day? You know, us Chinese 28, 8, Ifat. So maybe it was chosen because of an auspicious date. Is it because it was a birthday or someone special? Is it because it is very easy to remember 28/7, 2/8/7? Or is it because other dates have been taken up? So we recently celebrated World Dengue Day, if you've heard of World Dengue Day, World Anemia Day, World Tobacco Day. So there are 365 days a year. And so maybe every single day has been taken up by a World Something Day. So if you can cast your vote, that would be great. So I can see.
Somewhere special, easy to remember. Oh my God. I'm not sure myself. Okay, I think I'll send off. Okay, so we have a lot of people coming in now. Okay.
It is 50-50, it's getting a bit more in the birthday or someone special.
And you, it's your birthday.
I wish my birthday is on the 28th of July.
Wow, such a hepatologist. Passionate about the...
Oh,
I don't know what happened. Who did that? Can undo the blue thing, please? I don't know how. Okay. So what?
Right. So the answer is, it is a special birthday of someone. So this is Dr. Bloomberg. As exotic his name is, he's actually American. So he won the Nobel Prize in 1976 because he actually discovered hepatitis B virus. And 2 years later, he invented the virus, the Hep B vaccine. So
that was quick.
Yeah, within 2 years. So he's a very knowledgeable man. He actually did not do it alone. This Nobel Prize was a co-winner. There was a co-winner, but his background wasn't as clean as Dr. Bloomberg. So we chose his birthday instead of his counterpart's birthday.
Okay, you make me very curious. So what is so not clean about his counterpart?
You can Google it as to why 28th of July is chosen and who discovered hepatitis B and who invented hepatitis B vaccine. And who won the Nobel Prize in 1976 for hepatitis B.
Okay.
So back to the serious stuff, I think. So we'll go through a bit about hepatitis B, management of hepatitis B. Most of the information is taken from the CPG guidelines, which was published last year. As we all know, CPG guidelines are very easy to read. It's got very good summary in the beginning, has a lot of algorithms and tables and figures, which would help streamline management. So makes it very easy to read. So a bit about hepatitis B in Malaysia. So almost about 500,000 people are estimated to be living with hepatitis B. A very, very alarming thing is that 9 out of 10 people with hepatitis B don't know they have hepatitis B. So only one knows that they have hepatitis B. Maybe half of that one knows that they have hepatitis B and see a physician for his or her hepatitis B. So these are all very alarming numbers. If you can imagine 9 of them, maybe half of them are young mothers, and so they would give it to their babies. We know transmission of viral hepatitis B is mostly vertical, so mom to baby, mom to bub, or horizontal, so sexual, blood to blood, bodily fluids, blood-borne virus in terms of transmission. So the first that we want to touch is screening and diagnosis. So the next question should be, who should be screened for chronic hepatitis B infection? So again, if you have your phone, I'd appreciate if you can scan the QR and then write as much as you want. So there's no limit as to what you can write. Oh,
Who should be screened for hepatitis B?
correct.
Okay.
Who should you take blood tests to look for hepatitis B?
Is it the same Slido? No, huh?
It is, no, this one is a different one. You have to scan,
Okay, so I
scan
just
the
scan
QR
again,
again. These
Okay.
are all great answers. Everyone should be screened for hepatitis B infection.
Who should be screened?
Cost, maybe cost can be an issue. All adults age 18 and older. High-risk behavior is great. Pregnant mother, yes. Thalassemia patient. Patient who wants to start chemo, great. Very, very good one. And it's often something that we don't think about, but very, very important to think about. Elderly, CKD, TB patient, all very good answers. Healthcare workers, patients who want to start dialysis, high risk. So everyone is still right there in the middle, green, big. Everyone thinks everyone needs to be screened. I wonder, all 15 of us, have we ever been screened for hepatitis B infection?
I have.
Oh, we certainly have to. Okay. High-risk behaviors, healthcare workers, blood donors, pregnant mother, immunocompromised. They're all sort of
active crowd
showing.
here.
They're all showing big signs.
Everyone. Okay, everyone. Everyone at how? Oh, I got phone number there also. 0135122. Does that mean?
Genetics. All right. Thank you, everyone, for participating. So who should be screened? Close to everyone. But if it's close to everyone or everyone to be screened, then unfortunately our government probably don't have the money to do that. So they've recommended targeted screening, which means that in a person who is high risk of developing hepatitis B, for example, if they have a first-degree relative who has hepatitis B, everyone needs to be screened. The first-degree relatives need to be screened. The mothers, the fathers, the siblings, the kids, they all need to be screened for hepatitis B. Those who are living under the same roof with people with hepatitis B, even though not blood related. They should be screened also. The reason being, if they don't have antibodies, then they should be protected with vaccination. So it's more about protecting them than to actually look for hepatitis B infection. Blood donors, obviously, because they need to be screened for all types of blood-borne viruses. Healthcare workers, people like you and me, definitely need to be screened and protected if we don't have antibodies. People who inject drugs, migrant workers, pregnant women, especially pregnant women now, we are paying a lot of attention to pregnant women. This year, they made it mandatory for all pregnant women to have a hepatitis B serology to be checked because majority of the virus is given from the mother to the baby without knowing. So all pregnant women have to be screened for hepatitis B infection now so that we can pick them up, treat them, reduce the risk of transmission. Of course, there are other high-risk groups, people coming in for investigation of abnormal liver function tests, patients with chronic liver disease, STIs, patients on dialysis. They all need to be screened for hepatitis B infection. If they don't have hepatitis B infection, they should be vaccinated to protect them from getting hepatitis B infection. So before that, somebody talked about people who are going to start chemotherapy. They also should be screened. And these are one of the special population that I'll talk about later and why we need to screen people who start chemotherapy. What are the tests that we use to screen? Something similar to a COVID test. There are rapid diagnostic tests out there, a few drops of blood onto this slide, and then whether it's a positive or negative test. Most of us would do lab-based tests. So a lot of our patients would come in through their health checks, their annual health screening. They go out and buy a package. They have 1 million tubes sent off for blood, one of which is hepatitis B infection. So again, a very, very busy slide here. I apologize for that. So when we talk about hepatitis B serology, we are most familiar with the surface antigen up here, which tells us whether the patient has an active infection or not. So if the surface antigen is reactive or positive, depending on what lab test you look at, it would say that this patient, yes, has hepatitis B infection, active hepatitis B. The other tests that's usually on all these packages are surface antibody. If the surface antibody is present, it means that they are protected, they have immunity against hepatitis B virus. There are two other tests that we often do in secondary and tertiary centers. One is the core antibody. This means that the patient has had past infection. This remains very important if somebody does not have surface antigen. So surface antigen is negative, but their core antibody is positive. These patients have past infection. These ones are important to know in patients who need to start chemotherapy. And why we need to do that, again, I'll tell you later. The other one is E antigen. So E antigen, if it's positive, it means that there are a lot of viruses. So if it's E antigen positive, you know that the viruses are partying in the liver, they are procreating, they are having lots and lots of babies. So they have many, many, many copies of viruses, and they are very highly infective. So if we do an E antigen positive, we can suspect that this patient has a lot of viruses, and this is not that great news. So when somebody comes to see you, you found out that this patient has surface antigen that is positive or reactive. What is next? So I've broken it down to a few steps. So we'll start with step 1. So the first step is to decide whether this is true infection or not. The reason being, we give the hepatitis B vaccine in the form of surface antigen. So we inject a little bit of surface antigen into the deltoid in the muscles, and then our body would mount a response, an immune response, and then develop antibodies towards hepatitis B. So if we take blood immediately after vaccination, the surface antigen will be positive, and it will remain positive for up to 2 months. So we have to remember that, because I had a recent case where he was referred to us because his surface antigen was positive. We spoke to the patient was puzzled, saying, the doctors before that asked me to do a vaccine, so you're telling me now that I have hepatitis B infection? So they got a bit angry, of course. Then we checked, actually, yes, it was due to his surface antigen vaccination, and that can remain positive up to 2 months. So in these kind of cases that someone has a recent vaccination, we often recheck in 6 months' time, just to make sure they lose their surface antigen, and that it is actually not an infection, it is just because of the vaccination. If we speak to the patient's not had any vaccines recently, then we have to decide, okay, this surface antigen is positive. You haven't had a vaccine recently or within the last few months. So we think you probably have chronic hepatitis or hepatitis B infection. Is it acute or chronic? Depends on the timeline. So within the first 6 months, it's acute. After 6 months, it is chronic. So we can ask the patient, or when do you think you had it? Did you share needles? Did you do any naughties over the last 6 months? When do you think you were exposed to the virus? Often they would say, I don't know. And then you ask them if there's family history. Is there family history of liver problems? Then they think, oh, maybe someone in my family had yellowness in the eyes, jaundice, and had to go to hospital. And then within a week, they passed away. So I don't really know what happened. So these kind of history, liver cancer, liver cirrhosis, history, and most of the time it will be a chronic infection. So step 2, you found that this patient has surface antigen positive. You've identified that this patient hasn't had a vaccine recently. So you think this is a true infection, active infection. You refer to a gastro specialist or liver specialist. That is correct. And I think at the moment, we have not given the responsibility to primary care physicians to manage patients with hepatitis B infection, because it's such a complex virus. I often call it the clever, cunning, clinging virus as compared to hepatitis C, because hepatitis C you treat, you don't worry about it for the rest of his or her life. So these patients, yes, refer to us because we have to look after them longer term. But before referring to us, there are some things that we should look out for. So they come in surface antigen positive. Then you look for 3 main complications. The first one is liver cirrhosis, which means that if they've had infection for a long, long time, they could have liver inflammation for many, many years. The liver becomes hardened, becomes cirrhotic, and then they will be prone to complications of liver cirrhosis and portal hypertension. The second big one is liver cancer. So the virus itself are carcinogens. They can become, they can make the liver bad, and it can cause liver cancer without liver cirrhosis. So the virus itself can cause liver cancer. The third one is acute liver failure. So we'll go one by one. Liver cirrhosis and portal hypertension. If somebody has liver cirrhosis, often they would have a few signs and stigmata of chronic liver disease. So this here are spider nevi. So it looks like a little spider. Usually they'll be on the chest, upper arms, lower arms, and it's a sign of chronic liver disease. Females can have up to 3 of them, which is normal. But in males, and if in females there are more than 3, then most of the time it's because the liver is not doing very well. Jaundice is another sign of liver disease, and of course, ascites, fluid in the peritoneum. They are all stigmata of chronic liver disease. Most of the time, you would have done blood tests as well because they would have had a package of blood tests. What we can look at is their platelet count. If their platelet count is low, most of the time they would have portal hypertension. Look at their liver function tests, bilirubin, whether that's high. Again, that tells us that the liver is not functioning very well. Look at their coagulation studies. If their INR is high, again, the liver is not doing well. So all these can point towards liver cirrhosis and complications of liver cirrhosis. Most of the time in the clinic, you will have access to an ultrasound machine, or some patients, again, through a package would have had an ultrasound done. They will be looking for any liver cirrhosis changes as well. Fibrosis assessment, so looking at if they don't have any major signs or obvious signs of liver cirrhosis, do they have liver scarring? So in the past, we would stick a needle in to try to see whether they have liver cirrhosis or how much scarring there is. But nowadays, the clever people, they have invented all these scoring systems that we can calculate and predict whether the patients have a lot of scarring in the liver or not. So two of the more common scores that we use and recommended by our CPG guidelines is the APRI score. This one is the AST to platelet ratio index. So only use AST in platelet and they will calculate a score. The other one is FIB-4 score or fibrosis 4 score, and that include age, AST, ALT, platelet count. Again, it calculates, gives us a score, and then we can predict whether this patient has a lot of scarring or no liver cirrhosis at all, or they have liver cirrhosis. So these are very handy tools to use. The only caveat with FIB-4 score is the age. So if somebody who is 70 years and above, this score is probably not very accurate anymore. So you probably have heard about FibroScans. FibroScans, a big brand, came from Europe and France, and it's now made the gold standard for us to look for any scarring of the liver. So FibroScan is a brand, but what the technology uses is a vibration-controlled transient elastography. So basically, it measures how stiff the liver. So if you've gone to the markets, you've had an opportunity to look at innards, and if you had a look at a liver, it's nice and smooth and it's spongy. And so if there's a lot of scarring, it's hard, and so the liver is very, very stiff. So this is actually what they are measuring using this FibroScan machine. So at the moment, Beacon does not have it. UPM does not have it yet because it's an extremely expensive machine to have, and hopefully we will get it very soon. So assess for liver cirrhosis and portal hypertension, complications from that. The second one is to look for liver cancer. So I've had a few cases where they didn't know they have hepatitis B. Suddenly they came in, lost a lot of weight, a bit of right-sided abdominal pain. We did some blood tests, showed that the liver enzymes were raised. Did an ultrasound scan and one big liver tumor sitting in there. And then we screened for hepatitis B and that came back positive. So this is a very common scenario. So when you see a patient with hepatitis B infection, we have to ask whether they've had any weight loss, any constitutional symptoms, any right upper quadrant pain, and whether they've lost appetite or felt weak, and things like that. So on examination, whether there was any abdominal masses that you can feel. Most importantly, we do an alpha fetoprotein level, which is a tumor marker. It's not that sensitive or specific actually, but if it is raised 100 and above, then we will be highly suspicious that this is liver cancer. Obviously, ultrasound, if you have that available in the clinic, and we often diagnose them using a CT scan, CT4 phase or CT liver, just to see whether they've had the characteristics of liver cancer or not. So if somebody has hepatitis B infection, their lifetime risk of developing liver cancer is about 10 to 25%. So if I see 10 patients with hepatitis B infection, about 1 to 3 of them would have liver cancer. So again, that is a very, very alarming thing. That's why we have screening programs and surveillance programs. And in a patient who has hepatitis B, if they have a strong family history of liver cancer, we would screen them every 6 months, doing an ultrasound scan and AFP level. If they don't have a liver cancer family history, then once they reach 40 for males, 50 for females, then we start doing ultrasound scan and AFP level, regardless of whether they have liver cirrhosis or not, looking early detection of liver cancer, in which case we can treat it very, very early. Okay. Yeah.
May I know if there is any indication of which patients have an increased risk of liver cancer? For example, you say the HBe antigen.
Correct.
Is an indicator if it's higher?
Correct. So there are many, many risk factors, one of which is family history. So hepatitis B infection, they have many genotypes. We don't often test for the genotypes here, but there are certain genotypes which increases the risk of liver cancer. So if there's a family history of liver cancer, certainly that increases the risk of the patient's lifetime risk of liver cancer. Yes, you are very, very correct. E antigen positive, because they have many, many viruses. And obviously, the HBV DNA level, the many copies of viruses, how many copies of viruses in the bloodstream, the higher the level, the higher the risk of developing liver cancer in the future. So that's why there are some patients where we decide that, okay, we think your cancer risk is very high, but you don't actually fulfill any other criteria for treatment, we would still treat anyway. So if a patient's mother had liver cancer, their HBV DNA level would be less than 2,000. But because of that family history, I would want the HBV DNA level to really, really be suppressed, undetectable. So we completely try to eliminate the risk of liver cancer. So you are quite correct. Yeah.
Is the fact that the mother-to-child transmission also a risk factor as you start carrying the virus at such a young age?
So not all kids, when they get transmitted, that they would develop chronic infection. So there are quite a few phases of the infection in the past. We talked about the immune active phase, the immune tolerant phase. These terms have not been used now, in which case we use the chronic hepatitis or chronic infection phase. But the chronicity, I don't think the chronicity itself is a risk of liver cancer.
So the chronicity of carrying the virus is not, is the hyperactivity of the virus that counts.
Correct, because there are some patients who are termed inactive carrier, which means that even though they have surface antigen positive, but their viral load is very low. So those patients, we just monitor as well. We don't treat. So I'll talk a little bit about treatment later lah.
Okay.
Okay. So the third one will be acute liver failure. So when they come in, surface antigen positive, you look at them, you decide if they have acute liver failure or not. With the jaundice, the confusion, lethargy, hepatic encephalopathy, on the blood test, their INR is sky high. You ask them to do a hepatic flap, they're flapping away. So these patients need to be sent to emergency department straight away because they have acute liver failure. So these are the three main things that we would try to assess when a patient comes in with surface antigen positive. So we've done step 1, screening. Step 2, looking for any complications. Step 3, since you have the patient in front of you, if they have their partner or if they have their family, their kids, then they have to be screened for hepatitis B infection as well. So screen all the first-degree relatives, tell them that it's not their fault because a lot of the patients feel guilty for carrying the virus and giving the virus to their family. And often that's one rate-limiting step or limiting step for them to tell their family to be screened. They feel guilty. So we need to reassure them that it's not anybody's fault. If they want to blame, they should blame the doctors for not screening the mothers to look for hepatitis B. They should not blame themselves. So they all need to be screened. So step 4, if you have time, notify KKM, because then we would have statistics about how many people are diagnosed with hepatitis B, how old are they, and all sorts of different statistics. If you don't have time, if they come to secondary and tertiary care, we can report that as well. Okay, so that is the step 1 to 4. If you see a patient in your clinic with surface antigen positive, after that you refer them to us. Depending on what sort of symptoms they have, then we will decide about how soon we should see them. Of course, the acute liver failures, the decompensated liver cirrhosis, the HCCs, or you suspect the HCCs, we will try to see them as soon as possible. So when they come to see us, we would decide about whether we should start treatment or not. So the virus, this one is cunning, clever, clingy virus. And so not all patients with hepatitis B infection, we would start treatment, because if we were to start treatment, in the past, we have thought that they have to be on lifelong treatment. There is no real cure for hepatitis B infection. We can just control them. Whereas hepatitis C infection, we say, okay, you have hepatitis C infection. We give you some medications for 3 months and 6 months, and you'll be cured. For hepatitis B, it's not the case. The reason being, like I said, CCC, the clever, cunning, clinging virus, because they have their DNA embedded in our liver cells. Actually, the CCC DNA is called covalently closed circular DNA. So I've just changed it to clever, cunning, and clinging virus. So they stay in our liver. Even though we have cleared our surface antigen, this would still remain in our liver and can reactivate. So when do we start treatment? If there's any damage. So if I see the ALT, liver inflammation, ALT a bit high, if the patient has liver fibrosis, so if I calculate the fibrosis score, it's high, or if there are any obvious evidence that they have liver cirrhosis, those are the patients that I would treat. If they have a strong family history of liver cancer, I would treat them also so that I can suppress the virus. All the others, I would just monitor 3 to 6 monthly liver enzymes, 12 monthly HBV DNA levels. So again, the CPG guidelines gives us a very, very nice table, simplifies everything. All we need to do is decide if the patient has cirrhosis, whether they are E antigen positive or E antigen negative, look at their liver inflammation marker, the ALT, look at their viral level, and then decide if we need to start treatment or not. So I wouldn't go into detail for that because usually we try to do that in a secondary and tertiary center. So what are the drug choices? We call them the nukes. So it's like a nuclear bomb that we try to bomb them. So we call them nukes. So actually it stands for nucleotide or nucleoside analogs, but most of us call them nukes. So the 3 main ones that we use now is TDF, tenofovir disoproxil fumarate. The other one is TAF. This is one of my favorites now, TAF, tenofovir alafenamide, which is here. It's got a new generic one. So it's a bit more, it's a bit cheaper compared to the non-generic one. The other one is entecavir. So entecavir has been there for a long, long time as well. So the reason I prefer TAF because it's gentler on the kidneys and the bones. I recently saw a 72-year-old lady came in with back pain. She has been on TDF for 1 year. We did an X-ray. She's got osteoporotic fractures of the back. So we often try to avoid TDF in the older people. We start them on TAF instead because it's gentler on the bones. PEG interferon, we use it for E antigen positive because we want to seroconvert them. There are multiple side effects for PEG interferon. So feeling very unwell, like the flu, lots of mental health issues, those kind of side effects. The 3 medications down here, lamivudine, we don't usually use it anymore because the viruses get resistant to it very quickly. Talbivudine and adefovir, you would see it still floating around because it's got moderate resistance profile. But the best are still these 3, TDF, TAF, or entecavir. So now we go into the special population. As we talk about, we are targeting the pregnant women. So hopefully if we screen all pregnant women, we try to know if they have hepatitis B infection, we stop the transmission, we protect the baby, and so we would stop having that transmitted to everybody else. So again, the CPG gives us a very nice algorithm as to when we screen positive, what to look for. So not many centers would do a HBV DNA level. It will cost about 500 and 600 ringgit for one sample. So most centers could do E antigen. So as we talked about, E antigen positive, lots of babies, lots of procreation and multiplying viruses. So we can assume that the viruses are very high, in which case we should try to suppress the viruses, reduce the virus level, so that when the baby is born, the mother don't have that many viruses to give it to the baby. So it's safe to start from 28 weeks of pregnancy onwards. The choice of nuke is usually tenofovir, either TAF or TDF, only the tenofovirs because the others are not that safe for pregnancy. When the baby is born, they need to have immunoglobulin, the hepatitis B immunoglobulin within 12 hours, and also the vaccine within 24 hours. Okay, if the baby has been given immunoglobulin and vaccinations, they are safe to be breastfed. So we don't often ask them not to breastfeed because obviously breastfeeding is good, protects the baby, gives baby immunity. The second special population is you and me, healthcare workers, and the MMC has published a very strict guideline on blood-borne viral infections in healthcare workers. So they talked about exposure-prone procedures, which means that they've described it as if you have your hands inside someone's abdomen or inside someone's chest that you cannot see your hands, that is considered exposure-prone procedures. So if the healthcare worker wants to perform these kind of procedures, they must be on treatment. Their DNA level must be either undetectable or less than 50. And every 3 to 6 months, they need a HBV DNA level sent off just to make sure they remain low in their viral load or undetectable so that they don't transmit it to anyone else. The last but not least special population is what we talked about, patients who will be undergoing chemotherapy or any medications to suppress the immune system, even high-dose steroids for 4 weeks. They need to be checked for hepatitis B, present or past infection because of this cccDNA that's embedded in the hepatocytes and can be reactivated if the immune system is low. So how we screen, we look at the surface antigen to look for current infection. Obviously, if they have infection, they need to be started on a nuke therapy. If their core antibodies is positive, but the surface antigen is negative, then we look at what is their risk of having reactivation. So patients with chemotherapy would be at the higher risk. and these patients will be started on nuke prophylaxis. So hepatitis B, the tenofovir or entecavir during their process of chemotherapy. So the last thing that I'll be talking about, and I can't stress enough, is prevention and vaccination. So in 1989 is when hepatitis B vaccination has been incorporated into our national immunization program. So anyone born 1989 and beyond, I certainly don't fit into that category, but thank goodness I've been vaccinated. Everyone ideally should be vaccinated already, but we still get surprised sometimes. So the good doses are at 0, 1, and 6 months. This gives the ideal protection. There are accelerated ones like 0, 1, and 2 months. But the antibody titers would be less compared to this one. So most of them would require another booster at 12 months. So often we would have antibody titers of more than 10, about 1 to 3 months after vaccination. And we can check that if we want. For healthcare workers like you and me who are constantly being exposed to patients with chronic hepatitis B infection, ideally we should have our annual checks just to make sure we have enough antibodies, but nobody actually knows whether the titers are high, even though you have been vaccinated within the last 20 years, because we do have our memory B and T cells, which would still protect us for at least 20 years. So in summary, screen people who we think has to be protected against hepatitis B infection or has a risk of developing hepatitis B infection, actively screen them. Once we get a diagnosis, then we assess for any complications, refer them to secondary or tertiary care because these patients need to be followed up long-term. And remember to screen their family and their contacts, vaccinate, and hopefully we will try to eliminate hepatitis in the not too distant future. The WHO recommends elimination at 2030, which is 6 years down the line, but I don't think we're anywhere close. So I think that's my last slide, Betty.
Okay, great. Fantastic lecture. May I know if there's any questions? Okay.
Should I
First,
stop share?
not necessary, up to you.
Okay.
But can I ask you, so can we say safely that the hepatitis B vaccination has reduced the incidence of hepatitis?
Yes. Yes. So like we talked about, the virus, the hepatitis B virus is a preventive. We can prevent
That's right.
hepatitis B infection. So the immunization, the vaccination is effective. So with immunization, I think at the moment, seroprevalence, we have seen about 4%. It used to be about 9%. So it is coming down. We are getting control of it. We are a bit more aware and more active in trying to bring that down further.
So since most of the childbearing age mothers, they should actually would have been vaccinated, right? Because the program started about 35 years ago.
Correct. We still get some surprises.
Yes, that's right.
Unfortunately, I do have two mothers recently, I have two mothers that we found that on screening, they were tested positive.
So
They were
you
in their
cannot
30s.
assume,
No.
you cannot assume that we still need to screen, right? Because even though we say, okay, why do we screen pregnant mothers? After all, we have vaccinated everyone. So what is the seroconversion rate for most people after vaccination?
As in developing antibodies?
That's right.
Or,
That's right.
I don't have the numbers, but presumably everyone would respond to the vaccination. There are certain population who will not respond to it. One of which that I can remember is patients with HIV. So because they don't have the immune system to mount a response, so they wouldn't develop antibodies in that population. So maybe immunocompromised people, they don't mount that response. End-stage renal failure also, sometimes we may have to give them a few boosters to see they've developed the antibodies. But most of the immunocompetent people would have a response after the 3 doses of vaccines.
But I have seen patients who have had 3 doses of vaccine and have no antibody. Is it possible?
Then we have to check whether they have a competent immune system. It also depends on how quickly they got their boosters. So the recommended is 0, 1, and 6 months. So if they had the accelerated ones, the antibodies won't develop so quickly. So they need a booster at 12 months.
I see. Another thing I want to ask before I take all the questions from the chat group.
Yeah.
Are Chinese more susceptible to hepatitis B infection and its complications?
So we certainly do see more Chinese people with chronic hepatitis B infection. And whether they're susceptible, I'm not too sure. But we certainly see more Chinese people, and it's published in the literature as well that Chinese is number 1. I think Malays were number 2. The other way to look at it is that we are screening them more as well, or we pick them up more, so they come to clinic a bit more, as opposed to other ethnicity. So it's also
the urban area.
Yes, so the urban areas are the more prevalent areas. So I think in my second slide, the urban areas, we are picking more patients with seropositive hepatitis B infection because we are finding more.
Okay.
So they are coming forward more as well.
Okay, Alma Fahana asks, the presence of cirrhosis in the algorithm is dependent on ultrasound or the scoring of the fibro-APRI FIB4?
Usually we would look at the scoring system. So the FIB4 or the APRI score. Because liver ultrasound, unless it's very obvious, which means that they have irregular margin, the portal vein is dilated, they've got splenomegaly, they've got ascites, then you can make a diagnosis of cirrhosis. Sometimes what the ultrasound show is maybe a bit of coarse echo texture, but otherwise the size of the liver is normal. The spleen is not big, there's no ascites, the portal vein has a normal hepatopedal flow, then it's very hard for us to confidently say the patient has liver cirrhosis, just basing on that coarse echo texture that's being reported. So I'll be a bit more reliant on the FIB4 APRI score. If you look at the table, there are the in-betweens, so no cirrhosis and not cirrhosis. So the in-between ones are a bit more difficult to know, and that's when the fibroscan would come in handy.
Okay, you showed us some calculations, some formula to for I think risk, right?
About this one.
That's right.
Yes.
How do you come to this formula? It looks like some quantum theory formula.
The very clever people do that.
Okay. I'm like, oh my God, it's almost calculus to me. Okay, Karajit Kaur asked that she says she missed the part why hepatitis B is more cunning a virus than hepatitis C. And I'm also very curious about this because when I was a medical student, hepatitis C was incurable. And you know, when I was a medical student, it was ages ago. It was an incurable disease compared to hepatitis B. And we didn't even have vaccination. And suddenly, lo and behold, hepatitis C is a good prognosis kind of liver infection.
Correct.
So, yes.
So hepatitis C is an RNA virus, in which case the treatment now is so advanced and so easy. They take 2 tablets for 3 to 6 months, and their cure rate is about 99%. Viral hepatitis B, it's a DNA virus. So they've got, if I can show you the composition, it's a very complex composition. It's got layers and layers and layers. So that's why they've got the surface, they've got the envelope, and then they've got the core. So the trickiest part is because of this DNA. So they call it the CCC DNA, the covalently closed circular DNA. So every time I talk about this CCC, I've got to think about what the CCC means. That's why, because I'm so used to calling it the clever, cunning, clinging virus. So this CCC DNA would be embedded in the liver cells. So that's why it's very, very difficult to treat. The HBV DNA is embedded in our liver cells. So that is why it's quite complex and difficult to treat now.
So the B virus has a lot of C characters, and the C virus has a lot of B characters, like benign.
Yeah, it's easier, and because the treatment is so easy now. And
yeah, no, don't worry. We will invite you back to speak about hepatitis C treatment. That Karia asked, Dr. Lau, may I know if patients with alcohol abuse or NAFLD are more susceptible to hepatitis infection?
so certainly, if somebody has one thing that can cause liver damage, then any other things that can cause liver injury would be multiplying. So if somebody has viral hepatitis B infection, I would certainly ask them to cut down on alcohol, try not to drink that much. If they have fatty liver, get them to do diet and lifestyle changes, exercise. So they per se are not prone to viral hepatitis B because viral hepatitis B is transmitted through blood and bodily fluids, but they will be more prone to complications of liver cirrhosis. So they can accelerate, make the inflammation faster, make the damage to the liver faster, because the liver is a very forgiving organ. They can only cope so much. So if you keep on chuchuk them, at some point they would decompensate. Okay, I raised my white flag. You want to continue to damage me? I'm not going to repair myself anymore. So that's why it's supposedly a forgiving organ lah. So at some point we can reverse the damage. But if we pass that point of no return, then the damage is done, cirrhosis will come, liver cancer will come.
Can a liver cirrhotic patient from hepatitis get liver transplant?
Can, yes.
But if you don't treat the hepatitis B, then how?
We would still treat the hepatitis B. So anyone with liver cirrhosis, or that if they have advanced fibrosis, they're not quite cirrhosis yet, but they have a lot of liver damage, we would treat them. Because what we don't want them to do is decompensate. They have jaundice, go into proper liver failure lah, essentially. So those patients will be treated already.
Okay, then they can get the liver transplant.
Yes, there are a lot of other criteria.
Okay.
Yes, we can decide about liver transplant.
Okay. Chua Hui Gin asks, when a patient's blood result is hepatitis surface antigen negative, but hepatitis E antigen positive, what further tests would you do?
That is a very interesting question which I have not come across before.
Wouldn't the hepatitis E antigen be positive, then surface antigen will also be positive?
Correct. They go hand in hand.
Yes, so
I
Chua,
would
is
repeat.
it a case that you have seen, or is just, I just want to ask any question kind of question?
I will
Because,
repeat the test again.
yeah,
If you want to double, triply confirm, then you can do HBV DNA level, because there's also a subset population which I didn't talk about, something called occult hepatitis B infection. So basically their surface antigen is negative, but they have detectable HBV DNA level. So that's a subset population lah. So occult hepatitis B infection.
okay, so it is possible. So just repeat. So no, ASEAN asks, can nurses get infection of hepatitis after vaccine?
So if they have been vaccinated, technically they're protected. So I don't know if that question is meant for if you test their surface antigen level, then of course it'll be positive, because if they've had a vaccine recently, you do a surface antigen, it'll be positive for 2 months. So in that case, they don't have an active infection. It's just because of the vaccine causing the surface antigen positive.
On the same token, if you say everybody who has been vaccinated seroconvert and have antibody, we don't have to check pregnant women if they are at the age that is within where the vaccination program has started. True or not?
You have to think where they come from and whether their parents
But they will never know it themselves, right? Because
correct.
parents, yes.
Yeah, usually the national immunization program is rolled out to say that yes, we provide all these vaccines, but because the first dose is during 0 month,
Yes.
so within the first 24 hours, often they get vaccines, and then 1 month and then 6 months later. So it's up to the diligence of the parents lah to get that done.
Because I have also seen even a colleague who had polio, even though the vaccination program has been rolled out. Okay, we'll take a few more questions. Dr. Chan, so many questions today. People with hepatitis B history, can it be prevented to become hepatocellular carcinoma? I think just now we spoke about the treatment, right? The treatment can reduce the risk of cirrhosis and CA, right?
Correct. So it's not only treatment, but also active surveillance. So these patients, even though they are treated, maybe we lower their risk of HCC, but we still need to actively survey them. Often they feel that, oh, I'm on treatment, I don't need to go back to see the doctor, I just go to caring to collect my medications and just save my money to see the doctor. But actually, every 6 months, we do an ultrasound scan, do a serum AFP level, and then we can pick up early cancers. So again, there was one lady, chronic hepatitis B infection, every 6 months do an ultrasound scan. Ultrasound scan was normal, but AFP was just slowly creeping up. So the normal is less than 10. Hers was from 9 to about 11 to about 12. The daughter was a bit concerned. So we thought, okay, we'll do a CT scan, and there was a small, tiny 2 centimeter HCC. It was not found on ultrasound. So personally, I do both ultrasound and AFP level every 6 months.
Okay. Does COVID vaccine has an impact on hepatitis B antibody?
I've not come across that.
Okay.
I'll certainly look that up.
So we have to go fast. Dr. Yao asked from Doquity, what should we do if a patient is vaccinated by hepatitis B vaccine twice, but the titer is still negative? I think we answered that question just now, right?
Have another booster.
Yeah, have another booster. I'm not sure. So the booster actually when you're vaccinated and you have developed antibody, with a memory cell, it should last about 20 years, right?
Correct.
Not forever.
What I looked up is about 20 years. Nobody knows how
Okay,
long.
nobody knows.
Mm.
Okay, Dr. Key asks on Doquity, if hepatitis E antigen is positive and liver enzymes are within the normal range, does that require chemoprophylaxis? Chemoprophylaxis?
Does that mean that they are going for chemotherapy? If they are going for chemotherapy, I would start
No, I don't think
hepatitis B.
I'm not sure. Don't worry. We can't. We don't know what is the question like. So Karamjit would like to ask the treatment shown for hepatitis B, as shown just now, is it lifelong?
So there are very recent talks about functional cure. So some experts have started doing something where they monitor the HBV DNA level. If it's been consistently undetectable for 2 to 3 years, they may stop the medications and monitor them. So there are some instances where they lose their surface antigen. So if somebody is surface antigen positive, they become surface antigen negative. So they can define as functional cure if their HBV DNA level is undetectable. So there are many other factors that they look at before they stop the treatment. They look at the surface antigen titer as well, which unfortunately in UPM we don't do. I think UM has been doing it. So they would consider stopping the treatment because they are aiming for a functional cure, which means losing the surface antigen and then undetectable HBV DNA level of treatment. But of course, these ones have to be closely discussed with the patient. There is a risk of flare. I think the risk of flare is about 30% from memory. So,
Okay.
yes.
Is it safe to give hepatitis vaccination to a pregnant lady?
As long as it's not a live attenuated vaccine, I don't know. I don't think we do. I don't think we do. I'm not entirely sure about that one because we only check whether they have hepatitis B infection because we give surface antigen, so a bit of surface antigen to mount the immune response. Their immune system is probably not the best as well, so I wouldn't give them a vaccine.
Okay, Dr. Lau, Dr. Justin asks, when do we stop antiviral therapy for hepatitis B patient and declare that their treatment is successful?
When they have lost their surface antigen, so sometimes after a few years, if you're lucky enough, then we can recheck the surface antigen. If the surface antigen is negative, the HBV DNA level is undetectable, then you can stop. But that is like finding the pea in the mattresses.
Is it true that men tend to have has active hepatitis more than women?
No.
No, okay. Does HCC surveillance after the age of 40 to 50 apply to both cirrhotic and non-cirrhotic?
All cirrhotics need to be screened regardless of their age. So every patient who has liver cirrhosis, regardless of their age, we would screen. All liver cirrhosis, regardless of their etiology, the cause of their cirrhosis, we would screen. So all cirrhosis, screen. Hepatitis B without cirrhosis, 40 and 50 years of age, depending on whether they are male or female.
Okay, that's great. Can we watch recording again for chronic hepatitis tonight? No, you can't watch again because I have to put it either on YouTube or I have to find a way to do it. So not tonight. I'm really tired. I'm going to stop recording.